and PAs, and if you could draw a distinction between healthcare delivery that a physician would practice as well as an NP or a PA.
Mm-hmm. I can speak to our system, and everybody probably does things a little bit differently. In our organization, family nurse practitioners are primary care providers. Family physicians are primary care providers, and we don't currently have any PAs, but they would be primary care providers as well. I think in Connecticut, there's more of a tendency towards the specialty areas than primary care. You know, it's a question that's often asked, and I think we've taken this tack. We need people who want to be primary care providers trained to do as much as they possibly can. We are not currently providing care in the hospital setting. In Connecticut, that trend has been towards the hospitalists in the hospital setting and the primary care folks in the primary care area, and therefore, what we really focus on is the team. And the team can include physician, nurse practitioner, PA, responsible for a panel, but it's about everybody on that team. It's about the behavioralist and the nurse and the care coordinators, as well as it is that primary care provider.
We employ numerous nurse practitioners and PAs, and we wish we could employ even more numerous
Well,
PAs.
let me ask it another way. Do your nurse practitioners and our PAs essentially provide 70 to 80% of the same type of service that an MD would?
Yes,
in
so
terms
for
of
us,
their
they are the primary care provider. It's their own panel. They're not assisting anybody. They are the primary care provider, and their patients see them that way.
Are they able to prescribe
Yes.
medication?
Oh, yes, yes.
I think the big distinction came when we stopped going to the hospital, because that was always one of the differentiating areas. Only our physicians rounded and treated people in the hospital. But as we've pulled out of that, that's been different, which is not to say that we don't have tremendous appreciation for the expertise of everybody on the team. And people have expertise in certainly different areas.
Is that just a state of Connecticut that PAs and MPs are not allowed in hospitals?
It's not a question of not being allowed. We certainly, PAs and MPs do have privileges in hospitals, and that's fully allowed within the scope. Just the way that we have organized our system, we know where we need our primary care providers to be is in the office seeing patients, and we have great systems in Connecticut for the hospitalists.
Great.
I think Dr. Flinter hit on the key issue is, looking at the patient-centered medical home, it's the team. It's the whole team. A lot of time, we spend a lot of time arguing about who should be the coach or this or that, and that's not the argument we need to be having, except for the fact that we need to get coaches. The argument is, how do we provide a team that gets all the resources that this person puts? Mm-hmm. I remember lots of quotes, and the one that always jumps to my mind when I hear this is Benjamin Franklin, that we must all hang together or we will most assuredly hang separately.
Mm-hmm. Mm-hmm.
Actually, one of the things we're asking for is what we describe as the hit fix, and under the meaningful use piece, those PAs actually were excluded from getting that reimbursement. We hope that they would get back into that. So.
Right. Yep. Exactly. I would just say that, as you know, it can be quite a contentious issue, and I think that we need to be thinking of it as these overlapping circles, which not necessarily having clear boundaries. There are some places, I started as a nurse practitioner in my own clinic in West Philadelphia, but I had a lot of experience in adolescent healthcare, so felt more comfortable doing this. But I think the most important thing is, in this era of workforce shortage, it's ridiculous to have anyone not being able to practice doing everything they were trained to do and practicing to the full extent of that. And I think we need to look, especially in places like Oklahoma, poor Dr. Cole needs help over there, and we need to make sure that there's folks there that can practice fully and work with him in that team-based setting.
Mr. Miller.
Thank you very much. Thank you so much for your testimony. It's really helpful, and it's such a remarkable record. Obviously, I'm a fan. I've grown up my whole public life, I think, with community health. I think we had the first one in the nation, the federally qualified one in California, or in the nation. We were, one of the great gifts, I think, of this bill is in the future for people who lose their jobs, they won't lose their insurance after 2014. And we went through the same experience in my district, pretty blue collar, and a lot of people lost their jobs, but people who have insurance in my district, about 6 out of 10 have Kaiser. Mm-hmm. And it was a remarkable experience to talk to people who then came to the public, to the community health centers and to our public hospital. And they were, of course, they were shocked at the level of care that they got in terms of the quality of care. They thought this was some offbeat
Right,
system over
right,
here.
right.
And it was, I think, rewarding to people who worked in that system to have these patients come to them now in the middle of treatment they lost because of loss of insurance, and be so complimentary about the level of care and how they were welcome there and how they were followed up. But also pointed out, Dr. Cole, is this question of the medical records component of this, the ability to move those people's records horizontally into a different system is really so incredibly important. And again, with Kaiser, we have this tremendous electronic system, but in their combination now with Kaiser, with the veterans in some parts of California, again, is remarkable in these prompting and tracking people, whether the veterans are homeless or not. It's really quite amazing how they keep them engaged in the medical side of the Veterans Administration for their care on a regular basis as they kind of mobily move around California. So I just think this combination of the medical records and the kind of care and access and the cost of that care that you provide is every community ought to be clamoring for this. Once they understand it and see it, they are, and that's why a lot of new clinics are going up.
Yep.
But one of my interests is I've been on the education committee my whole time here, and that is what we see happen to kids, certainly in many of the poor neighborhoods where medical events and really leading one may be dentistry. Dental care really can interrupt their education rather in a dramatic fashion if they can't get access to care. And these in many cases are students that everybody is struggling to keep current as they progress through the fourth grade or fifth grade, whatever they're in. And we now have integrated that where they'll go pick the child up and bring him and do the dental care and put him back in school, hopefully all within a matter of a couple of hours. Is that becoming more common, or is that because the teachers just think it's great?
Sure.
But does this make sense? It looks like it makes sense to me.
Well, I think it makes sense, and I think I like to say, let's try and go one step further and go where the kids are.
Yeah.
So today, technology, both portable electronic health records, and I'm sure Dr. Cole can fire up his electronic health record of any patient while he's sitting here, as I could on my iPad. But we not only have the health information technology, but we have the care delivery technology. We go to 173 schools in Connecticut with these very sophisticated fold-up dental units, which we can put on the stage in the auditorium or in the nurse's office, unfold, do sealants, x-rays, complete cleaning, and send a dentist behind the hygienist on the next round to do the restorative care. You are absolutely right. And it's not just dentistry, it's behavioral health. It's about the upstream prevention of putting behavioral health therapists in schools and about the medical clinics, as Dr. Whalen had in Philadelphia. It's the upstream prevention. And dental, more than any, speaks to the issue of the lost potential of kids. The number one reason kids miss school in America is because they're in dental pain. We have finally moved the needle on that by, we call it Wherever You Are, or our WIA program. Go wherever you are, including 173 schools to deliver dental care. So I really appreciate you raising that issue. And I don't know what percentage of community health centers operate school-based health centers, but I suspect it's a very high one. We've been doing this since the 1990s, and I think we not only do upstream prevention, intervene early, but I think we're also teaching kids how to use healthcare down the road, teaching them how to effectively be their own best consumers of healthcare.
Thank you very much, Rose.
Thank you. I have a couple questions, and then I'll make a closing comment and ask Mr. Miller to do likewise. And as Mr. Miller pointed out, God, what and my other colleagues have, what an incredible panel. You think you know this information, and you supportive of these efforts, but what you've displayed today and the information and your own personal care and compassion around these issues is really gratifying to all of us. And it's going to keep us in the fight, my friends. It will keep us in the fight. A couple questions. And to Dr. Flinter, and to Ms. Harris. Dr. Flinter, you talked about continuing education and the nurse practitioners, physician assistants, et cetera. How do those opportunities get funded? What role do you have in that effort? How do you work with these folks and staff to encourage them to take advantage of these opportunities?
Well, thank you for that wonderful question. I think sort of divided into three quick buckets. One is the training we do for people who come to work for us. This is a cost of doing business. We are trying to equip our workers in order for us to be successful with the best skills, technology skills, as well as clinical skills, service skills. So that's one element of training. We just take it as a cost of doing business. The second is really the cost we take on because we are a community health center committed to our neighborhoods and committed to people continually advancing themselves. And that's the continuing education and the tuition reimbursement program. To see people going on first in their families to go to college is really so essentially part of what Jack Geiger and the others had in mind 45 years ago of improving neighborhoods, eliminating disparities. And the third bucket, honestly, I call that our cost of being innovators and leaders. The residency program you've heard us speak of for nurse practitioners, there is no funding for it. We have graduate medical education funding for lots of things, not for nurse practitioner residency. But we know that sometimes the most important thing we can do is give substance to a good idea, build the model, and then look for the funding. Because an idea is an idea, but a proven model that works, that's what can attract support. And as you know, we're trying to do that through the Affordable Care Act and in every other way we can. And I suspect everybody here at the table has programs like that where they've said, somebody's got to do it. Somebody's got to show what this looks like, and then we can attract the funding.
Ms. Harris, I say the same thing to you and your encouragement of students and so forth. And I go back to what my colleague, Representative Andrews, was talking about, and Mr. Miller knows this firsthand, as do my other colleagues. We're not only faced with looking at a cut in health services and the community health centers, but the education pieces attached to this is really so huge in terms of cutting off opportunity. And that's a question with you, Ms. Harris, in terms of what you do and how you encourage your students and how they get placed, et cetera.
Our school evolved from a husband and wife team that started out just providing CPR to the community. Mr. Johnson was a fireman, and had seen so many young children dying at scenes of fires because no one knew CPR. So he and his wife got together and started a CPR program. That evolved into a medical college where we were offering medical assistant programs, MMT programs, other healthcare programs, which has now evolved into a university, which now offers associate degrees, bachelor's degrees, master's degrees. And we train our students to go out into doctor's offices, health clinics, and billing programs, other kinds of medical facilities. Our funding comes a lot from the Department of Education because we are actually a school. So a lot of our funding comes from that. We get funding from the local community. We get funding from our accrediting agencies. We get funding from various places. But just as Dr. Flinter said, we are creative and we are innovative. And so we seek out fundings and support from the general community and nationwide where we can get it.
Dr. Whalen, in terms of your calculations at the center, 300,000 jobs, how did you get to that calculation?
What the model does is it shows when you've generated that much economic, we look to see what percentage of appropriated funds go into health centers. That's about 17%, 18% of their overall economic capacity. And then in order to make those, to expand those dollars into the economic, the growth in the indirect, direct, and induced areas, there's then a model that's actually localized to the different communities. And I'm not as familiar with the model, but it says in order to generate $1 million worth of economic activity, how many jobs will that take to do? So what's interesting about this is there's been some controversy about whether or not the jobs are going to be there because of the Affordable Care Act. And this model has been using real numbers for community health centers for a number of years, looking at with a current year funding, how many jobs has it created, how much economic economic activity has it created? So when we do the projections, it's from real numbers that's looking only 5 years out. So it's something that I think we can really get our hands around, and we can believe that this is what's happening. There's some have said, well, will this really happen? Can community health centers ramp up? And what we've seen is an enormous success that they've had with the stimulus dollars. As Representative Castor pointed out, that there was a parking lot, and before you knew it, it was up and it was running and it went. So there's no doubt that this money, when it goes to these areas, they'll do it. They'll get up, they'll get running, and they beat all of their odds on what they thought they'd be able to see with the stimulus dollars. Before the landmark came, they were up, they were seeing those patients, and they exceeded their goals. So we're really optimistic that these numbers are something we can count on, and that it's going to happen with this investment.
Thank you. I want to say thank you to Mr. Toomey and to Dr. Cole as well. If I can, just for a second, because Dr. Flinter mentioned Florentina, who I had the opportunity to meet and see on last Friday. She is also, by the way, a veteran, an Army veteran, and but it's just her comments. And Dr. Flinter went through what she went through, and this was her comment, which stuck with me. And as I wrote it down and kept it particularly for today. She says, they treated me with dignity. They didn't look at me like I was low income. They looked at me like I was a human being. And just to all of you, you create jobs, you save money, but you save lives, and you give the gift of life. So we are grateful to all of you for being here today. And as I say, you can count on us to make the fight with you to make sure that that we can reverse these cuts. So, Mr. Miller.
Well, thank you, and I want to associate myself with the remarks of my colleague, Rosa DeLauro, for exactly what she said. That's the great promise of the community health care centers, that you give us the ability to look at the challenge that we took on with the passage of the health care bill, and you give us a map to help meet that challenge, both in access and in affordability, and in the quality, ramping up the quality of care for millions of Americans that wouldn't have that access to quality care otherwise. So it's very exciting for us. This week we're celebrating both the signature on the health care bill and on the student loan bill. And so this combination really speaks to opportunity, and it speaks to economic security for families and for young people. And it's a very exciting time. And we're going to fight like hell to hold on to all of it, because this really is about strengthening our country. And but the healthcare centers have really been on that first line, and have been just magnificent to work with, and to see how they include the community in decisions and in care is just quite remarkable. So thank you for your testimony. Thank you for all of your involvement and your talents and sharing it with us. Thank you.
Thank you.
Thank you.
Thank you.
That the
Look at this.
hearing is
Are we
concluded.
punctual, or are we
Right,
punctual?
listen.
Thank you.
Thanks.
Oh.
Thanks, Karen.
Nice to meet you. I started out as a DOT.